Awesome, thanks, Jen. As Jen said, my name is Derr, and I am a pharmacist by training. I'm currently working as the medication management lead here at the Iowa Healthcare Collaborative. And today I'm going to talk a little bit about the importance of medication reconciliation in the inpatient setting. Today we will hit on what medication reconciliation is, how it relates to medication management. We'll talk a little bit about why MedRec is a best practice and standard of care. We'll compare different medication reconciliation models, share some tips and tricks for MedRec, and discuss the role of nursing and pharmacy in medication reconciliation. So let's start with the what, when, who, and why of medication reconciliation. So I really want to start off the presentation talking a little bit about medication management and what that is as a whole and where MedRec fits into that. So as you can see, this is from the Joint Commission of Pharmacy Practitioners, and it is our pharmacy patient care process. Basically, the way that we look at this is a continuum of how we do patient care, and MedRec is a piece of med management. You can see we start in that yellow little square there with collect, and this is where whichever healthcare professional is doing the medication reconciliation will get the subjective and objective information and review it in order to understand the relevant medical and medication history and clinical status of the patient. So when I think about this, this is really where MedRec fits into this entire continuum. So collect is really what MedRec is. The next step is going to be assess. And this is where the healthcare professional collects and analyzes the clinical effects of the patient's therapy and looking at the context of the overall patient health. Next, we move into plan, and this is where the healthcare professional really individualizes the patient care plan so that it fits best with what the patient's needs are and with what we have found in our collect and assess steps. The next step is going to be implement, and this is where the healthcare professional plans in collaboration with other healthcare professionals and the patient or caregiver in order to implement that plan. And then lastly, one of the most important steps is follow-up through monitoring and evaluation. I do want to draw your attention to the center of this entire process. You can see that it says patient-centered care. So really everything we do in this process is to be patient-centered and focus on how we can best care for the patient. Along the outside of the patient care there, it says collaborate, communicate, and document. And so those three are really key components of the healthcare team in order to make sure that they are getting the best out of both medication reconciliation and med management as a whole. So what is the definition of medication reconciliation, or MedRec? It is a conscientious, patient-centered, interprofessional process that supports optimal medication management. So again, it's patient-centered, and it is an interprofessional process. The best possible medication history provides the cornerstone for MedRec, and it is a little bit different from medical history, as we're focusing in on medications when we collect a medication history. And our goal is to make sure that any changes made to the patient's current medication, such as omission, dose changes, deletions, are intentional and based on the patient's current clinical status and desired care plan. So the key point in that goal is that any changes that are made are intentional and based on the patient's current clinical status. So when should we complete a medication reconciliation? At a minimum, MedRec should be done at admission and discharge. Ideally, MedRec should be completed with any transition of care. So hospital admission, transferring from one unit to another, discharging from the hospital to home or another facility such as long-term care, and transitioning from long-term care to another setting. So anytime they are moving from one unit or one type of care to another, we really should be performing medication reconciliation. And MedRec should also be completed with any new diagnosis or change in the patient's status. So who needs to have medication reconciliation completed? There's really multiple theories out there on this. Ideally, all patients should receive medication reconciliation. However, just for your information, there's a few theories out there. One is to focus on a patient over the age of 65 years old. So only those over 65 is one theory. Another theory is that they have a certain number of medications, and the kind of average that I was finding in this research was greater than 4 medications is when we should have a MedRec done. Or if they're a high-risk patient, such as frequent hospitalizations, if they're on high alert medications, if they're chronic disease prone to frequent medication changes. So this could be our patient who has diabetes and has frequent insulin changes. It could be our patient on warfarin that has frequent INR changes and frequent dose changes. But ideally, all patients should be receiving MedRec, especially upon admission and discharge. So why is it so important that every patient receive a MedRec? Patients often receive new medications upon transition of care, and they're not aware of what that medication may be, why they're taking it, or how to take it. And new medications can inadvertently place the patient at risk for adverse drug events. So I think that's the key piece, is that MedRec helps us limit those adverse drug events from occurring. And then with frequent changes in medication, the most recent medication and how the medication is taken is key to correct dosing inpatient. So we really need to know what their home regimen is and what they're taking inpatient before we can actually make a decision on how we want to treat that patient. And then evaluating medications and non-medication interactions will prevent, again, adverse drug-related events. So when we do a MedRec and you take that back to the pharmacist or the physician, they can really take a look to see if there's any concerns with drug interactions, food interactions, disease interactions. So it really is key that we cover all of our bases. Let's talk a little bit about models for medication reconciliation. There are several different models out there, and it just depends on what works best for your facility. So first I wanted to touch on our medication reconciliation in the hospital from our healthcare quality journal, and this one talks about several different levels of medication reconciliation using a bronze to diamond scale. So bronze would be the best practice medical history or medication history occurs at admission, and it's reconciled then. If we move up to silver, that includes both the admission reconciliation and then reconciliation by a prescriber only, plus or minus an electronically generated discharge prescription. So that gets a little confusing, but basically the way I look at this is silver is at admission, and then a prescriber reviews the reconciliation, or it goes into the generated discharge prescription. Gold is going to include everything in silver level, as well as discharge reconciliation being interprofessional and electronically generated discharge note. And then platinum, you're hitting everything in that gold level, but adding a broader medication management overview. So not only how are you taking this, which medication are you taking, but asking, okay, how can I help you better take this medication? What is your understanding of how to take this medication? And getting into more of that counseling. Additionally, it has more of a patient-friendly reconciled medication schedule upon discharge. So not only at admission, but we're also looking at it now at discharge. And then finally, our diamond level, or the one that we ideally want to get to, includes everything in the platinum level, plus additional elements such as post-discharge follow-up calls to the patient and communication of medication changes with the community pharmacist and their primary care provider. So that's really the idealistic level we want to get to, is that diamond piece where we're doing all of these core elements, but also have that follow-up piece, and we're communicating with their providers outside of the hospital. So who should lead medication reconciliation? And this gets a little bit more murky. There's definitely different models that you can utilize and different ways to do it. I think the key piece is at the bottom of this slide, that training of whichever healthcare professional completing medication reconciliation is key to the quality of that program. So healthcare providers should be able to evaluate the medication and then know when to address an issue. Do I need to talk to a physician? Do I need to talk to a pharmacist? Because it's a little bit more complicated than what I expected. So pharmacists are uniquely positioned and trained to lead and support patients and interprofessional teams with medication rec. And you will see some hospitals do have their pharmacists actually doing medication reconciliation. Additionally, a student pharmacist or an intern can provide a lower cost alternative. And I know that we only have schools really here in Iowa, at the University of Iowa in Iowa City, and then here at Drake in Des Moines. So some of those local hospitals in those two areas are utilizing student pharmacists or interns. Pharmacy technicians can be trained to do this and do medication history, and that actually can be really helpful for the pharmacist to have a pharmacy tech or a student go in and do an initial MedRec, and then they can come and step in as needed. I will note that in the Board of Pharmacy rules, you cannot, by law, say medication reconciliation technician. And so some hospitals are saying medication history technicians. It's a simple verbiage issue, but just something to note. And then nursing staff is also a great opportunity to utilize when pharmacy staff is unavailable, especially at our more critical access hospitals who may not have a full-time pharmacist on staff. But again, that training piece is really the key. Let's talk a little bit about tips and tricks to perform stellar medication reconciliation. So there are several different best practices, and we'll kind of walk through each of these individually so that I can give you some more information on each. So best possible medication history on admission. This is where the patient comes in, you interview the patient or family to obtain their current med list. It is then reviewed with at least one source, such as their primary care provider, their pharmacy, or if a patient has a list that they carry with them. And then you create a systematic process and document. Again, documentation is key. And then lastly, post the medication list in the patient medical record. So that is the best possible medication history on admission that we think through. So if we're being more proactive, medication reconciliation on admission, we get the best possible medical history, and then we use the list to write admission orders. So the prescriber will decide on what they want to continue, hold, modify, or discontinue. And then we implement the initial admission medication orders. So really starting with that, we get the patient list, the provider decides what changes need to happen, and then we implement that into their care in the hospital. We're looking more at a retroactive medication reconciliation at admission. This is where you have the initial admission. You compare the initial admission medication orders with the medication history that you get. And if there's discrepancies, we document why we changed that and what we're changing the patient to. You implement an initial admission medication orders and then create a medication administration record. And then the last step is ensure both medication administration and best possible medication history is in the patient record. So when I think of this one, it's more retroactive. Patient comes in, we do some sort of medication orders before we actually do our med rec. Then we reconcile any discrepancies and go through the rest of the process of actually implementing the medication protocol for the patient inpatient. This one gets a little bit more complicated, but can be a really useful chart for you to have in your units, especially upon an internal transfer. So med rec should be happening when you do have an internal transfer as well. And this is where you'll look at, is the patient being transferred to a new unit, a new service, a different healthcare team? Is their level of care changing? And then you will go through the arrows and go yes or no. So if it is changing, then our medication order is being written. Yes. Okay, we'll compare that with their best possible medication history and their current MAR inpatient. If it's not changing, then you can still compare it to their best possible medical history and their current MAR. And then you kind of walk through, are there any discrepancies? If yes, we need to contact the prescriber and resolve the discrepancy, and then continue down that to the implement, update the medication administration record, and ensure that the MAR and best possible medical history are available in the patient's medical record. So again, this is a great thing for you to have printed off and in your unit, just to determine when and how a medication reconciliation should happen at transfer, and if there's several other steps you need to take, such as resolving any discrepancies that come up. And then medication reconciliation at discharge. So this is an important step as well to make sure that the patient has a list to take home and that we are communicating it with the primary care provider and their local community pharmacy. So if the patient is being discharged from the facility, are they going outpatient or are they going to remain inpatient? If they're not going outpatient, then no action is required. If they are going outpatient, then the physician needs to write the discharge orders and prescriptions for any new or changed medications to be taken. And again, this is where we're going to compare it back to the best possible medical history and evaluate to make sure that there aren't any changes, such as new medications, discontinued medications, etc. And if there are any discrepancies, then again, we're going to communicate with the best possible medical history, as well as make sure that we're communicating with the patient, the community pharmacy, the primary care physician, and any other services they may receive. So thinking about specialty care or others that they may be seeing, and then we can discharge the patient. When we do that communication with our outside healthcare providers, we want to make sure they are aware of new medications, discontinued medications, adjusted medications, and if there's anything unchanged, we want to make sure they're aware of that as well. So patient involvement post-discharge, and this is probably one of the most important pieces. We have the best possible medical history on discharge. We've got our plan. We have the instructions for the patient to take home upon discharge. And then we want to make sure we do that community outreach to help them with any med list development, maintenance by patients or family, community pharmacist, primary care physician, and any other healthcare team that may need to know about this. That's where the patient and family will develop and maintain a complete list of their medications and what they're taking, and then they will provide that to their caregiver when they go into any different healthcare organizations, or even if they're at home and have home health or home nursing helping out. So when we're doing a medication reconciliation interview, these are the things that we want to make sure we're hitting on. With medications, we want to touch on anything that's prescribed. So oftentimes patients will think yeah, you know, I'm taking lisinopril, I'm taking this and that because my doctor prescribed it to me. But also talk about over-the-counter medications. Vitamins and herbals are getting to be bigger and bigger right now, so double checking with the patient on those. Nutraceuticals and health supplements are also something that I'm seeing a lot more of, so asking about those. And then things such as respiratory therapy, patients often forget that they're using an inhaler or that that's even something that they need to bring up. Any medical devices they may have, and then implants such as IUDs is an important thing to ask about. When we're looking at the medication information, we want to hit on the name of the medication, the strength. Formulation is one that is often missed. So is it extended release? Is it controlled delivery? Is it immediate release? Talk about dose, route, frequency, and then when did they have their last dose? If they're able to recall, that can be really helpful for us to know when we should start dosing inpatient. This is a great chart to consider if you do have any discrepancies. What should you do and how do we go about it? So this is the critical thinking process to identify and clarify discrepancies. We have the one-to-one match, where medications are ordered for the patient when they're in the hospital or upon discharge, and we match with what the patient was taking on admission. So this is an example of a patient taking furosemide 40 milligrams by mouth twice daily at home, and that's also ordered upon admission. There's really no need to pull in the physician and have any questions about that unless we don't feel that that medication is indicated for that patient. However, if there's no discrepancy, we don't need to grab the physician for that. If there's an intended discrepancy, so this is purposeful, these exist but are appropriate based on the patient's plan of care and what information we gather when they come in. So this could be antibiotics are started for an infection. It could be warfarin and aspirin are held because they have a procedure coming up. Again, those all have purposeful and intentional reasons that they are doing that, and so we do not need to necessarily follow up with the physician on that. However, both of those are something that we want to make sure we're training whoever is doing MedRec on how to actually make that decision and when they do need to pull the physician or other provider in. An unintended discrepancy is where a discrepancy exists and requires clarification of intent. Usually there's no supporting documentation explaining why the change was made. And so that's where the patient may be taking her blood pressure medication twice daily at home, but is ordered for only once daily in the inpatient side. And there's really no indication for why this frequency changed and the patient's blood pressure seems slightly elevated. Then at that point, yes, we would want to pull a physician in and consult for a resolution of any of these changes and make sure that we have this clarified and know why this change was made. So again, just a good chart for your reference to help you walk through and help with some of that training as you train somebody to do MedRec. The other thing I wanted to bring up is motivational interviewing. It's really important that we use some of these skills when we're talking to our patients, specifically because we can get the best information that we can when we use these types of skills. So using both open-ended and closed-ended questions. When you're asking a patient how they take a medication, ask it that way and not, are you still taking this medication? A lot of times patients don't want to admit if they're doing something that they view as wrong or incorrect. And so asking that open-ended question is really key. Ask patient about routes of administration other than oral medications. Are they using anything on their skin? Do they have eye drops, ear drops, inhalers? All of those questions are key to make sure we have the most accurate medication history. Ask about the types of providers that prescribe the medications. I've actually found when I was in practice, I would say, are you seeing a cardiologist? Are you seeing a dermatologist? And that would kind of spark something in them to say, oh yeah, I am taking a medication for that. I should probably mention it to you. Ask if their doctor recently started them on anything new, stopped any medications, or made changes to their medications, as that can be something that they forget if it's a more recent change. And then, of course, our OTC prompts to help make sure we know if they're taking anything over the counter. I usually like to go from head to toe, so asking about headaches, ask about allergies, do they use anything when they try to fall asleep? What do you take when you have a cold? What about heartburn? What if you have some pain or you bumped your knee and you have a little bit of swelling? Kind of asking that head to toe scan can help pull out any over-the-counter medications that they either didn't think about or forgot to even mention. So post-discharge follow-up, I kind of alluded to this in the very beginning, but this is really a key piece that we're seeing some hospitals and clinics even try to figure out how to do this. And like I said, this is one of our key pieces right there, follow-up, monitor and evaluate, especially because we want to make sure that when they go home, they have an effective care plan and that any modifications we made are in collaboration with our other healthcare professionals. and that the patient and caregiver really know what to do and what to take and when they should be using these medications. I know I've talked to several patients, and I'm sure many of you on the phone can attest to this as well, where when they go home discharged, they have 2 different strengths of their furosemide at home, and they're taking both, or they're taking their old strength because they didn't realize they needed to change over. So this follow-up call can really head off adverse drug events if we catch them early enough. So who should complete the follow-up call? Ideally a pharmacist, as they are the medication experts and are able to really think on their feet and help with any issues that may come up around medications. Otherwise, I've seen discharge educators, so nursing staff, or social workers even can help with getting our follow-up call done. So all of those are relevant healthcare professionals to keep in mind. The one thing I want to remind you again is training is very key. So the Agency for Healthcare Research and Quality has what they had termed their RED training program, and I highly recommend that you go check out this program. It has basically 12 steps to walk you through not only how to set up a medication reconciliation program, but the last couple of modules are all around the follow-up call and how do we perform a follow-up call. They even have some great videos and some great lists as well as documentation forms to help you get started with what you think would be a great program and how that could really move forward and help your facility do the best that they can with not only MedRec, but also follow-up. It is very important when you do have a follow-up call set up that you prepare for the phone call. Remember that the goal of the phone call is to ensure continuity of care and communicate with the healthcare professional who completed the patient discharge prior to making the phone call, even if it's through going through the chart and trying to understand what all happened inpatient, if you were not the one caring for that patient while they were in the hospital. Also make sure that you take some time to familiarize yourself with both the patient by reviewing the information about the hospital stay, and just make sure that you really kind of know the patient inside and out before you give them that call. Again, there's some example scripting and a checklist for a pre-call at our RED toolkit on AHRQ's website, so I highly recommend checking that out and using some of those key pieces to help with your program. How do you conduct a post-discharge follow-up call? Well, it's an essential part of supporting the patient from the time of discharge until their first follow-up appointment. Ideally, this should be completed within 2 to 3 days. That's usually when we start to see patients kind of fall off the wagon and not be taking their medications right. So try and make those clarifications within 48 to 72 hours. I do suggest waiting until after that 1-day mark. Give them some time to settle in at home. They may not have even been to the pharmacy yet to pick up their new meds. They just really aren't quite ready to have those calls on that first day home. And then during this call, you want to make sure to review their current health status. So how are they doing today? Have they had any changes? Medication, so make sure they understand their medications. Any upcoming appointments that you're aware of? How are their home services going? Do they have a caregiver there to help them out? Are they around as much as they expected? And then plan to do for what to do if a problem does arise. We'll kind of walk through each of these briefly here. So assessing their health status, we want to review the reason for their hospitalization so that we know why they came in. What changes have they had since discharge? Has their health deteriorated? Are they struggling with anything? And then discussing a plan of action for that patient if there is some sort of issue that has come up. Assess the understanding of when to seek medical care if concerns do arise. So going through each of those steps with the patient to make sure that they understand why they went to the hospital, how they're doing at home, and what to do if something does come up. With the medication check, this is going to be the longest part of your call. And I typically, when I did follow-up calls in the clinic side, I would plan for 30 to 60 minutes on this. And I know that's not always realistic for all facilities, but that's really how you tease out the most information that you need from a patient, as it takes probably 10 to 15 minutes to fully get their buy-in and their trust for most patients. This is where I would spend most of my time was on the med check. And so we would review each medication. What is the name of it? What time are they taking it? How much do they take? How do they take it? You'd be amazed how many patients don't know how to use an inhaler properly, or with some of our inhalers, it's not meant to be a tablet that's swallowed, but rather inhaled, and they'll swallow the tablet. Why are they taking the medication? And what problems or side effects are they experiencing? Encourage the patient to share the most accurate information, and again, that comes back to the importance of trust and making sure that we've established that trust with the patient. And then let's consider non-adherence. What if they are non-adherent? So they could be intentionally non-adherent, just decide they don't want to take it or don't know how to take it, so they're not going to. It could be inadvertent non-adherence. They may not even realize that they're not taking the medication properly. Or it could be something that there was a system or provider error that we need to correct because we did not give them the correct information or even possibly the correct medication. Clarifying appointments is really important in this step. So discuss any upcoming scheduled appointments. Keep in mind that the patient may have already gone to see their primary care provider prior to your call. And just make sure to review the dates, the times, the locations, why they're having that appointment, and just as importantly, talk about transportation. Oftentimes patients won't have transportation, and so they will not go to their appointment. So helping them establish that with a social worker or somebody in your local community to help with that transportation is key. And then also discuss any lab tests they may need. That way they're prepared when they come in. So if they need to get a lipid panel, make sure that they're aware of that so that they are fasting when they come in. Coordinate your post-discharge home services. So has the patient received any home services? What services have they received? How are those going? Is the patient using any durable medical equipment? And then talking a little bit about, do they have pets? Do they have any rugs or loose items that they could catch on and fall? And then have caregivers been available as expected? Sometimes you'll go home and expect that mom's getting checked in by her daughter frequently, but the daughter's only coming once a week when she was expecting 3 times a week. So asking all those questions is very important. And then plan if a problem arises. Always end the call with what to do if a problem arises at any time. Talk about emergency situations that may come up, what to do in case of that emergency, and how to contact their primary care provider after hours or when they need to go to urgent care or the emergency department. And then this is probably the most important part of the call. As much as the medications take time, you want to make sure that you go back and confirm their understanding. So throughout the call, you'll need to confirm that the person you're speaking with understands what you're discussing, and the teach-back method is a great way to do this. So remind the patients this is not a test of their knowledge. It's a test of how well you, as a healthcare provider, explained the concepts that you needed to discuss with them today. Use this technique with all of your patients, including those who you think understand, as well as those who are kind of struggling to understand what is happening. I found some patients can be very good at seeming like they understand, but they actually have some confusion and don't ask the questions that they need to ask. And then if the patient cannot accurately repeat what you ask them, clarify the information again. Do this until the patient can describe the directions in his or her own words. And again, there's a great video that I have the link for here on teachback, kind of the do's and don'ts and how to best ask some of those questions so that it doesn't look like you're testing the patient, but rather making sure that they understand everything that you shared with them. And then again, document and share. So document your call, including the number of times you attempted a call, what their health status is, any medication status or problems that they discussed with you, appointment status, post-discharge actions, so what are they doing now that they're home, and follow-up actions that you may take. And again, if you don't document this, it didn't happen, so as we always say, document, document, document. Again, there's some example documentation that can be found at this link from the AHRQ Red Toolkit. And then communication with the primary care provider is really key. So whether that's email, EMR, fax, or phone, making sure that they have this information from that follow-up call and are prepared if the patient has not come in for their follow-up appointment yet. And with that, I'll hand it back to Jen, unless there's any questions.
All right, thank you very much, Sarah. Any questions or comments for Sarah? Please go ahead and throw them in the chat box while I move to the next presentation here. All right. There is one question again about PowerPoints being sent out. Yes, the presentations will be available